Hi everyone, Dr. Mike here. In this video, we're taking a look at menopause physiology. And specifically, we're focusing on pre-menopause, perimenopause, and menopause itself, looking at the hormones and the physiological effects that can occur at every individual stage or period. Let's take a look. All right, so to begin, let's define premenopause, perimenopause, and menopause. So if we have a look at premenopause, effectively, premenopause is referring to the reproductive years. So it's from the onset of menstruation. So this is going to be a term that we use as menarche, that's the onset of menstruation. Generally happening when puberty hits, so around about 12, 13 years of age. So it's from that period onto perimenopause. So let's write that down. So pre-menopause is from the onset of menstruation all the way to the perimenopause period. Perimenopause occurs when you start to get variability or changes in the reproductive cycle. So it could be the length of the reproductive cycle. So generally the reproductive cycle is 28 days. It can be as low as 23, as high as 28, but changes happening every time, every month. It could be a shortening of the reproductive cycle, a lengthening, or even an absence, and other changes in between. So variability in the reproductive cycle all the way to menopause is what characterizes perimenopause. And then menopause is referring to the time period in which 12 months after the last menstruation onwards is menopause. So once there's been 1 year and there's been no menstruation, that is the beginning of menopause, and that continues on. So 12 months since the last menstruation. All right, so we've now classified our three various periods. We need to now talk about what happens in each state. We need to talk about the hormones. 5 hormones we need to talk about today: estrogen, progesterone, inhibin B, follicle stimulating hormone, and luteinizing hormone. So we need to talk about what happens during the reproductive years. So remember, this is the reproductive years. Effectively from puberty onwards to perimenopause, reproductive years. So what happens during these reproductive years? I've done multiple videos on it, but we're going to do a summation of it here. So in the ovary, what is occurring? I need to draw up something in order to do this. So I need to draw up the brain. So that's the brain from a side-on view, not a roast chicken. Underneath the brain, we have an important region called the hypothalamus. So there's the hypothalamus. I'm enlarging it for the sake of the image. And there's an extension of the hypothalamus called the pituitary gland. And the pituitary gland has 2 aspects to it. I know that is looking quite weird, but that's the hypothalamus and that's the pituitary gland. Now there's an anterior and a posterior. We're focusing on the anterior pituitary gland. Let's put that aside for a second. So in the reproductive years, what is happening within the ovary? So before this premenopause phase, before the reproductive years, let's just say a female is 20 weeks gestation. So she's developing in her mother's uterus, and at about 20 weeks of that gestational development, inside of their ovary, or ovaries I should say, because there's 2, there's around about 6 to 7 million oocytes. These are eggs, 6 to 7 million. But by the time they reach this premenopausal stage, right, around about 12 years of age, they've got probably around about 300,000 to 500,000. So they've lost millions of oocytes. How? Through atresia, through simply just the death of these oocytes occurring. Why? We don't really know, but we know that as the years progress, oocytes continually die off and get broken down and reabsorbed back into the body. So by the time we hit this point here, the onset of menstruation, there's around about, let's say, 300,000 oocytes remaining. All right. By the time we hit perimenopause, there's probably around about 400. So let's write this down. It's probably important to write down. Here, we've got around about 300,000 oocytes. So remember, oocytes are eggs. Here, we've got around about 400 oocytes And by the time we hit menopause, it's between 0 to 100 oocytes. Okay, so effectively, you've exhausted the amount of eggs, oocytes, by the time menopause has been reached. So what is happening? Let's picture we're in the ovary, okay? We know that at the beginning of every reproductive cycle, so I'm going to also draw up a table here, and this is going to have our hormones on it. So this is going to be time period. This is going to be day 0, that's going to be day 14, and let's say we're taking the typical 28-day reproductive cycle. And we're going to go through the various hormones. So to begin, what happens? Well, at the beginning of every month, day 0, multiple follicles start to grow and develop. All right. Now, follicles are the oocyte, the egg, surrounded by cells. So if I were to say, all right, here we go, there's an oocyte. We know that multiple oocytes start to grow and develop within follicles. Now, follicles have 2 major types of cells associated with them. You've got a group of cells that directly surround them, called granulosa cells. So I'm just going to draw them because not all follicles are at the same stage. Some are big, some are small. So these are the granulosa cells, right? Granulosa. And then there's another cell type on the outside called theca cells. So they are theca cells. Now, at the beginning of every reproductive month, a dozen to multiple dozens can start to undergo this process where they start to get bigger. Now, here's the interesting thing. If we look at what's happening at day 0, when all of this is beginning, and they start to grow and develop these follicles, you have 2 important hormones that their levels start to rise. We have follicle stimulating hormone, and we have luteinizing hormone. Now, the hypothalamus releases a really important hormone called gonadotropin releasing hormone. Gonadotropin releasing hormone. Now, gonadotropin releasing hormone travels down this stalk to the anterior aspect of the pituitary gland and stimulates it to release follicle stimulating hormone, FSH, and luteinizing hormone, LH. Now let's write those full names down, right? Just so you know what I'm referring to. So at the beginning of the reproductive month, gonadotropin releasing hormones released from the hypothalamus, travels down to the anterior pituitary, releases FSH and LH. So you start to get this rise of FSH and you start to get a rise, but a little bit less, of LH. Now this is important because granulosa and theca cells have receptors for FSH and LH. Specifically, the granulosa cells, right, have receptors for FSH. So you can see all of these granulosa cells have receptors for FSH. So that means FSH, which we're going to highlight by a blue dot, is going to bind to the granulosa cells. Brilliant. Now the other great thing is that the theca cells have luteinizing hormone receptors. So they've got luteinizing hormone receptors. Brilliant. So as these levels of FSH and LH start to go up, these hormones bind to their respective receptors on the granulosa and theca cells. Now, if we have a closer look and see what's happening inside these granulosa and theca cells, let's draw up, so the theca cells are in red, so there's a theca cell. Let's draw up a granulosa cell. The theca cells have cholesterol in them, okay? So the theca cells have cholesterol. And when luteinizing hormone binds to the theca cells, it stimulates the cholesterol to turn into androgens. Now, androgens are generally termed male sex hormones. And you might be thinking, but this is happening in the ovary. Doesn't matter because they're also the precursors for estrogen. Now the theca cells cannot convert androgens to estrogen. What they need to do is hand those androgens off to the granulosa cells. And what the granulosa cells can do is take those androgens and with the help of follicle stimulating hormone binding to them, it triggers those androgens to turn into estrogen. So effectively, through FSH and LH here, stimulating these follicles to grow and get bigger. So remember, as FSH and LH are binding, they're stimulating these follicles to grow and get bigger. And as they grow and get bigger, they're producing a whole bunch of estrogen, right? So let's think about this. Let's make estrogen red in color, all right? So they're producing a whole bunch of estrogen. Now, it's not the only thing that's being produced by these cells. Not only is estrogen being produced, but another hormone called inhibin B. And inhibin B is also being produced. Now, inhibin sounds like inhibitory, and that's exactly what it is. It's inhibitory, and I'm going to talk about that in a sec. So, as FSH and LH bind to these follicles, they produce estrogen and inhibin. Estrogen and inhibin travel to the hypothalamus and they inhibit FSH and LH from being released. So effectively what happens is estrogen inhibits both FSH and LH and inhibin B inhibits mainly just FSH. So what happens is, as the estrogen levels go up, right? So we've got FSH and LH going up, binding, these are growing and developing, producing estrogen. So estrogen levels start to go up, right? But because estrogen levels are going up and inhibin levels also go up, now inhibin levels go up a lot faster than estrogen. It basically will go across and just go boink, like that. Because of the inhibin and estrogen both going up, they inhibit FSH and LH. So FSH and LH actually start to drop down. They go in the opposite direction of the inhibin and the estrogen, right? They start to drop down. Now you might be thinking, they're not dropping down to zero, they just become fewer, right? Now you might be thinking, why would we want to drop FSH and LH? Don't they stimulate these follicles to grow? Yes, think about this. All of these follicles that are growing and developing are different sizes. And if you've got fewer FSH and fewer LH, right? Who gets it, right? It's like having, a dozen people, but you've only got, 3 apples to hand out. Who's going to get it? The biggest, greediest person. Mine, okay? Pushing the others away. So the FSH and LH get gobbled up by the biggest follicle, this one here. And as that one gobbles up the very little FSH and LH available, what do you think happens to the others? The others start to die off. This is a term that we use called atresia. That's called atresia. This is the dying off of those cells, of the follicles, sorry. So only one gets selected. Now, as that one gets selected to grow and develop, it gets really big, right? Because it's the only one that's selected. And this follicle, there's the oocyte inside, starts to develop really big granulosa cells, multiple layers, really big granulosa cells, starts to develop the theca cells on the outside, brilliant. Now, what do you think this also means? The bigger it gets, the more estrogen and inhibin it produces. So it's going to produce more estrogen and it's going to produce more inhibin. Now you might then go, well, that means we get even more reduction in FSH and LH. No, because for whatever reason, we don't know why, when estrogen levels get really high, it's stimulatory. So it stimulates LH and it stimulates FSH. But inhibin levels are also going up. And inhibin remains inhibitory, right? So as inhibin remains inhibitory, it still inhibits FSH. So what we end up getting now in this period is that FSH it's saying stop, go, stop, go, stop, go, stop, go, stop, go. So we just get a little rise in FSH, not a big one. We just get a little rise in FSH. But LH is stimulated. So now LH goes through the roof, right? Now what's happening with these other hormones? Estrogen's going up and inhibin had gone up, right? So think about this. We've now stimulated LH. What LH does is LH starts to degrade away at this follicle. Nom, 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 nom. As it eats away at this follicle, it allows for the oocyte to be released, right? And that's ovulation. So at day 14, we get ovulation happening. And it's due to that spike in LH. Now, I need to write estrogen here because I've drawn it up on the graph, and inhibin. So I've spoken about 4 of these hormones so far. So we've got, now what's happening to these levels by this particular time? So that's gone up, it starts to go back down. FSH had a little bit of a spike, and estrogen keeps going up. All right, we've now had ovulation at day 14 due to the spike in luteinizing hormone. What happens now is that oocyte gets taken up by the fallopian tube, also known as the uterine tube. Hopefully it gets, in the eyes of the oocyte, gets fertilized by a sperm and wants to be implanted into the uterus. This thing that's remaining, this body, is now termed the corpus luteum, right? It's termed the corpus luteum. And this corpus luteum, I'm going to get one more pen. This corpus luteum, meaning yellow body, produces progesterone. So this thing starts to produce progesterone. And this is why after day 14, you've got low levels of progesterone, but then the progesterone levels start to go up and last for around about 10 days. If there's no fertilization and implantation, this thing dies off, no more progesterone, and the progesterone levels will then drop off. Estrogen is also produced by this corpus luteum, so we also have estrogen being produced, so you also get estrogen levels. Even though it goes down, goes up a little bit, and again, will drop down if there's no implantation, and the other hormone levels will drop down. They start to go low again. And finally, LH starts to drop back down and go low. Now, effectively, in the ovary, these are the 2 time points here. The first one is called the follicular phase. This is called the follicular phase because obviously it's due to the development of these follicles. This last 14 days is called the luteal phase, and it's called the luteal phase because of the corpus luteum driving the progesterone and estrogen in that latter 14 days, or at least 10 days here. So follicular phase, luteal phase. Now, this is what happens during this premenopausal period, so in the reproductive years. We need to now talk about what happens when we hit the perimenopausal stage. So effectively, the main thing that's happening anatomically, physiologically, is a significant drop in the ovarian follicles. So these things. We've only got 400 now remaining-ish, right? So at this stage, at the beginning of each reproductive month, instead of having, a dozen to multiple dozens, we've got far fewer. So let's think about this. So let's just draw some up. Now, just like we had before, they're going to be at different stages, Some are going to be a little bit developed, some not very much. Some will be far more developed. They've also got their theca cells, so the follicles are effectively the same. Sometimes their quality will reduce. Definitely by menopause, the quality in these follicles have reduced. And what happens is, again, let's think about the beginning of the reproductive month. FSH and LH go up, right? That's the blue, that's the black. They go up. And we said that as FSH and LH go up, they bind to their respective receptors on the granulosa cells for FSH, so there's FSH, and on the theca cells for LH. Now, let's have a think about this, right? So, they're binding. There's fewer cells here. They produce estrogen. And we said as estrogen gets released, it has an in the early phases, as estrogen starts to rise, so relatively low but increasing levels of estrogen are inhibitory for FSH and LH. The problem here is that because there's so few follicles, the estrogen and the inhibin that's produced are pretty low because there's not many follicles to produce them. So they're pretty low. So their inhibitory effect here is crap, right? Their inhibitory effect here is crap. So unlike in the early stages where we inhibit FSH and LH, you actually get a rise in FSH and LH in the perimenopausal period, right? So that means we end up getting more and more FSH and LH. So remember, here there was less, which meant the biggest one gobbled it all up and it was selected to move forward. The others died off because they didn't get it. But here, because we've got so much, here's the FSH available, and we've got so much LH available, all these available follicles get selected and move forward. In actual fact, FSH and LH here, they'll just keep going up. And what that means is, think about it, we wanted to inhibit LH. If FSH and LH go up here, particularly FSH, they all move forward, which means they all get bigger, which means they all then produce not low levels of estrogen and inhibin, but really quite high levels of estrogen and inhibin, because they're all getting bigger. Here it was just one, right? But here they're all getting bigger. So the estrogen levels go through the roof, inhibin levels go through the roof, and what do you think that means? I said that really high levels of estrogen stimulated LH. So earlier than usual, we get a peak in LH. We get a peak in LH. So if I were to just draw up this graph, just a very small version of this graph, 0, 14, 28. We said that early on, we've got, FSH goes up, LH goes up, but our estrogen levels remain low. So there's no inhibition. So what happens? FSH levels keep going up, LH levels keep going up, right? That results in all of them getting selected, and then you get this boom in estrogen because they're all growing. That results in a giant, now, because estrogen levels have gone up heaps, so is inhibin, which means that then inhibits FSH, but we get a crazy spike in LH super early, right? Well before day 14. So what happens is ovulation doesn't happen at day 14, it happens earlier. So in perimenopause, particularly the early stages of perimenopause, ovulation can happen earlier, which means the follicular phase is shortened, the whole cycle is shortened. So in the early phases of perimenopause, what you can get are shortened cycles. Shortened cycles. Simply because, again, I'll just reiterate because I know it's quite complex. Shortened cycles because there's fewer follicles, and as they move forward and FSH and LH get released as normal, they bind to the receptors, but estrogen, because there's not many, doesn't go up very high. So there's no negative inhibition, right? There's no negative effects. So FSH and LH just keep going up, selecting all the follicles. They all get bigger. They all release estrogen and inhibin, so they all go through the roof. So inhibin inhibits FSH, but estrogen stimulates LH, which stimulates, as we know, ovulation. So ovulation happens earlier, shortening the entire cycle, right? So, and then the rest happens as per normal, right? But the whole cycle is shortened. Then, when we move into menopause, we have even fewer of these follicles. Now I want you to think about what that means. We have even fewer. So if we have fewer, let's just draw two up. And we've got the granulosa cells. And we've got the theca cells. As per normal, excuse me, FSH and LH get released early on, binding to the granulosa cells. FSH binds to the granulosa cells. LH binds to the theca cells. Right? They start to release what? Estrogen and inhibin. Now, do you think there's going to be a lot of estrogen and inhibin, or do you think there's going to be not much? The answer is not much, right? So what do you think that means? We get spikes in FSH and LH. So we get really high FSH and really high LH. Now this is what happened here in the perimenopausal state. But remember, the outcome was, because we selected all the follicles, heaps of estrogen and heaps of inhibin. But because we don't have many, the estrogen and inhibin levels remain low. They remain low. We don't get that spike, which means there's no negative effects on FSH and LH. So FSH and LH just remain high, but because estrogen and inhibin are low, we don't get the LH surge, meaning you don't get ovulation. So effectively, in the menopause state, because the estrogen levels are so low, you do not get ovulation. No ovulation. And even some months, no follicles are recruited. All right? So estrogen and inhibin are so low, FSH and LH go up. The LH spike isn't so high that it results in ovulation. It's still high, but you need that really high estrogen to make that LH really spike for ovulation. So you don't get any ovulation. This is when we said after 12 months from last menstruation, you're not getting any ovulation in this period because you've either got no or very few oocytes. What happens to progesterone? Well, if we don't create a corpus luteum because there's no ovulation, we don't produce progesterone. So effectively, menopause is, what's going to happen in menopause is you're going to have high FSH, high LH, low estrogen, and low progesterone. High FSH, high LH, low estrogen, low progesterone. And you don't get that ovulation because of such low estrogen and progesterone. Now, to finish this off, it's important to talk about some of the physiological effects which are due to the low estrogen and low progesterone. So now, these individuals, usually early 50s, I should probably write that down. It's different for everybody, but usually early 50s is when menopause kicks in. What's happening is that there's some physiological changes. So a couple of important physiological changes. I don't have a lot of space here, but what I'm going to do is I'll wipe this off here and pop it down. So some of the physiological changes that occur during menopause include things like vasomotor effects. Vasomotor, so this is blood vessels and blood vessel diameter. So the vasomotor effects include hot flashes, sometimes termed hot flushes, and night sweats. Very common. Now, generally speaking, the hypothalamus, which we drew up before, that's the thermoregulatory center. So it's the thermostat for the body. And we've got a range, right? We know that our body temperature, at least in Celsius, around about 37 degrees, plus or minus 1 degree or so. So there's a range that it can sit within. We know that quote unquote normally, we've got that range. If it goes too high, we're getting too hot. And that means we sweat and our blood vessels relax and dilate to release the heat. If it goes too low, it means we're getting too cold. Our blood vessels constrict to hold on to the heat and we shiver to generate heat. Now, what tends to happen, we don't necessarily know why, but during the menopause, the hypothalamus is obviously going to have changes associated with it, and we get a narrowing of the thermoregulatory center, a narrowing of the thermostat, so the range, which means when your body temperature is quote unquote normal, you tend to feel hot and you get blood vessels dilating, So that's going to be the hot flashes, but also you're going to have sweating because it thinks that the body temperature is too hot. So that's the vasomotor effects. You also have urogenital effects. So this is both the urinary tract, but also the reproductive tract. So types of things that can happen here is dryness of the vagina. Now that happens because of a number of changes occur. So the epithelia, the lining changes, the cells that produce the lubricant changes and reduces the elasticity. So the connective tissue changes as well, so it can narrow and shorten. Other effects include pH change. So the pH tends to go up. So that means more basic or more alkaline. Now the problem with that is that it's a low pH in the vagina that usually allows for stopping bacteria, killing bacteria off. So increased risk of UTIs because of that reason. And also change, and this is probably psychological, but also it's physiological, is libido changes. So decreased libido, so sexual drive. You've also got increased risk of depression, brain fog, memory changes, and so forth. You've also got other changes that can occur. So you can have issues, so metabolic disease, I'll do a different color, increased risk of metabolic disease. So metabolic disease includes insulin resistance. Insulin resistance includes obesity, includes increased blood pressure, so hypertension, HTN, hypertension. All of these can increase the risk of developing diabetes, but also cardiovascular disease, and also an increased risk of osteoporosis. And the reason why that is the case, now this is usually due to what's happening from the perimenopausal state to the menopausal state. When the estrogen levels continue to drop down, that stimulates osteoclast activity. Stimulates osteoclast activity. Now osteoclasts are those eating cells. They eat the bone. So that's what we call bone reabsorption. So generally, as you grow and develop, there's a balance between you building bone and breaking bone. And that balance remains, right? If you need to build bone, you will. If you need to break it, you will. But when estrogen levels drop, it leads to a predominance of osteoclasts, so more breaking the bone down, and that leads to osteoporosis, increased risk of fractures. So look, all of this is a summary, an overview of what's happening in the pre-menopause, perimenopause, and menopause states. I'm Dr. Mike. I hope that helps.